Good afternoon, everybody. A very warm welcome to our audience present here in the room, as well as those watching us online. My name is Namrata Kaneri, and I am a Commonwealth Rutherford Fellow with the University of York at the Center for Global Health Histories, which is also a WHO collaborating center, and we are co-hosting today's webinar. It's called Man Up, Masculinities and Mental Health, Health-Seeking Behaviors, and it is 7th in the series of Culture and Health webinar 2019. The schedule is posted here in many places, and it is also available online should some of you want to revisit some of our earlier seminars. This seminar, and I'm very pleased to say this, is meant to showcase the Health Evidence Network report on the Cultural Context of Health project, and one of our authors is present here. He's a panelist here, and the report should be out later this year. I must also add that this webinar is the final of webinars of 2019 being held here at the UNCT Copenhagen. The remaining 2 webinars for 2019 will be held at Exeter, our collaborating partner on this, as well as at York. On 8th October, at the University of Exeter, we will have a seminar on the cultural context of palliative care, and it's provocatively titled, What Indeed is a Good Death? The final webinar will be hosted by us at the University of York on 5th November, which is a Tuesday. It's being organized to commemorate 40 years of smallpox eradication, and I invite all of you to join us in person at York or join us online, as that webinar will also be live streamed, just as this one is, for our worldwide audiences. Just to remind you that this series is a collaboration between the Evidence for Health and Well-being in Context project, which is being run out of the WHO Regional Office for Europe, and it operates under the umbrella of European Health Information Initiative, with York and Exeter as collaborating partners, generously supported by the Wellcome Trust. The aim of the webinar series is to bring in conversation social scientists, historians, people working in the humanities, with people of WHO, working in the WHO, and those in the wider UN system, as well as people from the public, to converse about cultural, material, economic context of health. And this dialogue is essential to improve our understanding of global public health. On 10th September, we have the World Suicide Prevention Day this year, and the theme for the World Mental Health Day on 10th October is suicide prevention as well. And therefore, this is a good opportunity for me to advertise the month-long campaign that the WHO will be running, joining both these themes. I would now like to introduce our fantastic panel, which is present here, and I will introduce them largely in the order that they will make their presentations. To my left is Professor Brendan Gough. He is a professor of social psychology at Leeds Beckett University in the UK and a fellow of the Academy of Social Sciences. He's a critical social psychologist and qualitative researcher interested in gender identities, mostly in the context of health and well-being. He has researched and written extensively on this topic, many textbooks, also handbooks on critical social psychiatry, and in 2014, he edited a major 5-volume series published by Sage on mental health and masculinities and on qualitative research in psychology. He's a co-editor and co-founder of the journal Qualitative Research in Psychology. He is co-editor-in-chief of the journal Social and Personality Psychology Compass and is associate editor, for the journal Psychology of Men and Masculinity. He's also the co-author of the report with Professor Irina Novikova at the University of Latvia of the Cultural Context of Health report. Second speaker is Isabel Yordi, who is the program manager for gender and health and human rights at the WHO Regional Office here in Copenhagen. This program is in the division of Policy and Governance for Health and Well-being and is in charge of mainstreaming gender and providing technical assistance to the 53 member countries of WHO Europe. She has more than 20 years of international experience with the United Nations on gender, strategic planning, as well as health. We're very happy to have you. Our third speaker is Giancarlo Gaglioni, to my extreme left, and he has been campaigning for mental health awareness since 2012 when he lost his talented young brother, aged 26, who took his own life unexpectedly. Giancarlo's main charity initiative is called the Mental Health World Cup, wherein he uses football to talk about mental health and promote the idea that it's okay not to be okay, or it's okay to be not okay. Each year, the tournament reaches a wide audience, and despite that, the number of suicides that are happening are increasing, they're not decreasing, and that is the question that he wants to discuss in today's talk. He also lives in the UK, which I heard today has 89 men killing themselves every week, which is almost like an epidemic situation. He works in the construction industry, which also deals with issues of masculinity, risks of suicide, and so on. In this talk, Giancarlo will share his first-hand experience of handling these issues and also his thoughts on what more needs to be done. Our speakers will speak for a maximum of 7 minutes, and then we'll invite questions and comments. Just this for our online audiences who are on Slido, you can look for the hashtag WHOCH, and you will be able to ask questions. I believe this is an option available to the audience available here as well. You can upvote and downvote questions so that we know which are the most popular and wanted questions, and then these can be forwarded to the panelists. Finally, some housekeeping instructions before I let the esteemed panel speak. We'll pass on some evaluation forms, and our online audiences can also give feedback in the polls section. You can also share your email with us, and you can be added to the CCH mailing list. And now finally, I do not want to stand between our panel and the audience, as well as the online audience present here. So I request Isabel to give a very brief launching pad into this whole panel.
Thank you, Marat. I'm jumping a little bit on the line because I was not the first speaker, but I wanted to mention that this piece of work on mental health is the result of a dialogue between several divisions in the region, in the regional office, that for the last 2 years, 3 years, have been working on men's health report and a strategy on men's health. It's the first WHO region that ever has a men's health strategy, and it's a comprehensive strategy towards men's health with a gender approach. One of the areas that we thought in this process of developing the strategy that deserved more in-depth analysis was the area of masculinities and mental health. And this is how this piece of work that Brandon is going to present came about. So I just wanted to give a little bit what it is, the framework within the WHO work of the initiative that we are discussing here. Thank you, Brandon.
Thanks, Isabel. So I'm one of the co-authors of the report with Irina Novikova from Latvia. And just very briefly, we were asked to look at the role of masculinities in help seeking for men's mental health behaviours. And we reviewed literature from the Anglophone world and Russian-speaking, Russian language literature. So we covered a range of research, both qualitative and quantitative, from different regions. On the Anglophone side, it has to be said that most of the evidence is actually from North America, Canada, the UK, with little pockets of evidence in Scandinavia and elsewhere. So just to start off, it's worth reminding ourselves of some of the headlines. We know that men, in general, are underdiagnosed for things like depression. And alongside that, we know that the suicide rate for men is very high, 3 times as high as for women. So when you put those two things together, you start to ask, well, what is happening with men? What is the problem? And of course, some researchers have focused on the role of masculinity in creating barriers to men's help seeking, because if men are committing suicide and not engaging with services, they're not seeking help, either formally or informally. So over the past 15 to 20 years, researchers across the world have been looking at the role of masculinities. Now, just quickly, masculinity is often talked about in the plural term now, in terms of masculinities, because it's now seen as a kind of multifaceted, complex and fluid set of elements that operate differently in different situations for different communities. So just bear that in mind. We can't treat all men as homogenous or masculinity as a unitary construct. So what we're finding is that particular masculinity constructs like self-reliance, independence, emotional repression, all things that are associated with men and masculinity in different regions, in different ways, create expectations and pressures on men to behave or not behave in particular ways. And we find then that these masculinity elements are influential in preventing men from coming forward to talk about any emotions or mental health problems. So, particularly in communities where these masculinity constructs are quite powerful, and we know that specific subgroups of men are less likely to seek help. For example, sexual minority men are less likely to come forward with any problems, and that's not just because of gender issues, it's because of wider social determinants, because we know that minority groups like gay and bisexual men are also subject to homophobia, often from a young age, which creates a climate of fear and suspicion and mistrust, so they don't feel they can come forward and speak to anyone. They don't see anyone in mainstream services that can assist them in their quest for help. So we have a stigma around mental health generally in many countries, but that stigma is almost accentuated for many men because of the stigma created by masculinity pressures. So there's almost a double stigma. And we tend to find that many men delay seeking help, if they ever seek help at all, until a crisis point emerges, so that they're very far down the line when they actually do seek help, and so that creates a burden on health services. Now, just to recap, so we've found that masculinity is one significant factor in constraining men's help-seeking behaviour for mental health issues. It is one of many factors. We have to bear in mind economic conditions, the experiences of minorities, prejudice and discrimination, the work situation, employment. We find a lot of men these days are working in precarious situations, flitting between temporary jobs and not being paid very much, having periods of unemployment. We know that unemployment and unstable employment has an impact on mental health. So it's not just gender, it's a whole constellation of factors which are impinging on men's mental health. Now, in the literature, we also looked at some initiatives to try and tackle male mental health in different communities. And there are a number of common features of programs that seem to have some impact. For example, it seems that a lot of men prefer to have therapy outside the clinic and in the community, so that men are more comfortable, perhaps, in a non-clinical environment, speaking with peers, not necessarily experts, or there could be mentors from the local community who are trusted and respected. Now, of course, different communities will have different resources and mentors who are available, but it's important that any initiative targeting men targets specific communities and creates buy-in and investment from local community members and leaders. We've also found some evidence that online initiatives are popular with many men, because if you think about it, men are anonymous in an online environment. They can find out information about mental health, but also talk to other men in forums, for example, and share experiences. And there's some evidence, it's quite limited, it's emerging, that these online environments can benefit a lot of men. Also, we're finding that language is important, straying away from medical terminology and using more everyday common sense terms, like feeling rubbish instead of feeling depressed. Those kind of psychological terms men don't tend to like generally. And what we've identified from the literature as well is that there are very few initiatives targeting boys and young men. And if we're going to help to prevent serious mental health problems and suicide in men, we need to start early. We need to do more research and intervention work involving different agencies and agents like parents, like schools and youth clubs, so that boys and young men are taught about resilience, are given strategies to deal with difficulties, and know where to go for support and help, both informally and formally. Thank you.
Okay, thank you very much. So I'm going to bring it a little bit broader to the men's health strategy and the gender umbrella. And the slide you have there, it's basically the framework that Gender and Health, the WHO, we are working with. And there was a women's health strategy before the men's health strategy and a women's health report. And actually, there are many links between the two in terms of mental health, and we are bringing those two together for implementation. And I would say that maybe mental health and gender is one of the, I wouldn't say failures, but I think that call for attention of, as Brandon has said, the gender paradox. We have this data for decades that women are diagnosed with depression much more than men, and men kill themselves many more times than women do. We know that there is an or the suspicion that women are overdiagnosed with depression and men are missing from the system. For us, the term of masculinities that we used in the report is not a new term, and Brandon has been making research about that for a long time, but it was a very good word to call the attention that gender norms are also a determinant of men's health. But what it was important for us, it was also that these masculinities is not just an individual responsibility. It's not about men or women doing differently. And I say men and women because what we were looking at is that masculinities as a society way of working are perpetuated by men and women, but not only as individuals, but they are also perpetuated by the health services, which is our concern. What can we do as a health service? They are perpetuated by the providers, by the teachers, regardless of their sex. It's just norms that we all work with. So it was a very good way of addressing that gender norms are also a determinant of and influence the way that we provide services. Another important way or issue that we highlighted in both strategies that follow a little bit a similar methodology is looking at the change of these norms and masculinities for mental health and for other issues. It's not, I think that this data is very striking, but it's not the only area where those differences have perpetuated. It's the fact that when we have these structures, they also change across the life course. It's not the same type of masculinities that adolescents at school are perpetuating than the ones of older men that may be experiencing loneliness in a different way to women because of the expectations that they have in older age. And actually, I think that also has been a striking issue in terms of suicide among older men. But it's important also that it's not either blaming men for following masculinities, but also not victimizing them. And when we look at the interactions with other structures and with other determinants of health, we highlight issues that are particularly damaging, like it's true that there are other issues that influence, like economic power and employment, but the way that they have a different impact of men and women, it's usually due to gender norms. With the breadwinner model that most of the Western European and traditional societies have, the pressure on men for not being unemployed are much higher than on women. And the way that we are socializing that pressure, it's very different from the very, very early childhood. We collected at some point a number of sentences that you tell boys and girls from very, very early age of how do they express or how do they behave. What we try to do also on the recommendations, also a very important link between the two and particularly important for mental health, is a compromise with gender equality. We are trying to make a gender equality agenda a good for the society, where actually we have some data from Sweden and Nordic countries where we see that high levels of gender equality do actually benefit in some outcomes, health outcomes, more men than women. And to see how it becomes also an engaging agenda. And that also the non-binary and the links between masculinities, femininities with sexual orientation and gender identity, how that also can be explored from very early child education. So we did try we have some recommendations on the strategy, they are online, but we do look very much also at what it is the health system's response. We look at what it is the capacity of the healthcare providers to identify those men at risk, those differences between men and women that can be given for expectations. What are the skills that they need? How do they reach our communities? And in which setups do they need to be present, like schools, workplace, etc. We also try to have some policy coherence, and I think that the use of data in this case is very important. We have had sex disaggregated data for decades, but if we don't use and we keep on presenting the differences without doing anything about it, we are not doing our work right. So we have the data because we want to do something about it, not just because at some point it's almost like a biological factor that men are killing themselves more than women. So we do need to have strategies that address those differences, and they link it with the other determinants. And we also have to work with communities, and I think that what you were saying, and I know that we will talk more about that, about on the one hand reaching men where men are, but not perpetuating our stereotypes. Not perpetuating that men have to man up, not perpetuating that men only respond to messages of strength and power and then we adapt of our strategies. And that's the scale you have on the picture, on the PowerPoint that we work with, that we go from gender unequal to transformative. So we may be, there are good experiences of reaching men where men are, and construction and football clubs and sports facilities are a natural place that we cannot miss. But we may want to go a little bit further and be more transformative, and so that we also reach those men that do not identify themselves with these expectations of power and strength. And we start working, and one of the links that we have very strong in both strategy is the care part. And the link with gender equality in terms of care and paid and unpaid care roles. The assumption is that when men start taking care of others, and fatherhood, for instance, is a very good entry point in terms of how do you transmit those messages of mental health and well-being and making them familiar with the services, they are more aware of their own needs and they know what the services can offer, and the services need to have also that transformation. And I leave it here. Thank you.
Thank you. Thank you both. And I think my part today really is to go a bit further and give my personal story of my experiences with mental health. It's clear through the discussions today that mental health is incredibly complex and we can't just understand it very easily. There is no magic pill out there that will instantly solve the epidemic that is affecting men all around Europe. Back in 2012, I lost my youngest brother, Lanfranco, who was only 26 years old, to suicide. Before that point, I had no idea that it was the biggest killer of men in the UK and continues to be the biggest killer of men in the UK. Before that time, I used to have stereotypes of what kind of person would take their own lives. Would they be homeless? Would they have mental health issues? Would they be depressed, have financial difficulties? What I found when my brother passed away is that he was the opposite of all those things. He was a fun-loving guy, he had a beautiful girlfriend, had a promising career in teaching. So it was a real shock to the system that suddenly, if it could happen to my brother, it could happen to anyone. And for anyone who's ever lost someone through suicide, it leaves a real blank in your family, and you want to try and do something. It was clear that my brother, just like many men around Europe, he suffered in silence. So for the few months up to where he took his own life, he didn't tell anyone. He just was that brave, strong man who could take on the world. But looking back at that time, were there any opportunities or things that we could talk about today that could have helped him, that could have saved his life? There's 5 areas that I'd like to share and hopefully start the discussions today, and they're very closely linked to what Brendan and Isabel are saying. The first bit is knowledge. Nowadays, when we need a question asked, we all turn to the same place. We don't tend to ask the person next to us or ring our friend. We tend to go to Google. Go to Google to ask any sort of question. And what happens is that we become so reliant on that tool that we're not only asking questions about work or about where to go to eat tonight, but we're asking bigger life questions, like my brother did. Because when he passed away, we had no idea he was suffering from depression. So I went through his internet history to find out how did it lead to that. And it's very clear through his internet history, there was a clear path that he was typing to Google, the questions that eventually led to him taking his own life. It started off with very innocent questions like, how do I get away from it all? How do I volunteer in another country? How can I become a Tibetan monk? But slowly over time, those questions became darker and darker. He started asking, how many pills does it take to take your own life? What's the best way to commit suicide? Should I leave a suicide note for my family? It was very clear to me, looking through that trail, that he was going to take his own life. And part of it for me is, should social media companies, internet companies out there do something more to use those cookies to try and save a life? Because they're great at capturing cookies and trying to sell us stuff. But wouldn't it be amazing if they captured those cookies and then done something about it, promoted other mental health charities, poked a friend to say, hey, why don't you get in touch with that friend you haven't spoken to? The next part that I looked at was awareness. So my brother did tell 2 people before he took his own life in that week, the week before he took his own life. He told his girlfriend and his best friend. They both said what most people would say, go and see your doctor, go see your local GP. The doctor prescribed him sleeping pills. Within 48 hours, he was dead. He didn't even open the box. When I found that out, I just understood that the magnitude of depression with men just isn't realised in the UK when it comes to medical health services. For me, depression is a little bit like when you're on a train track walking towards a cliff. For whatever reason, when men open up about depression and say that they're suffering, they tend to be a lot further down the track than when women do. And I don't know why that is. But when my brother opened up to that doctor, he was on the edge of the cliff. The doctor just thought he was at the beginning. So I have spent some time talking to doctors in the UK about when a man comes into your surgery and says they're having suicidal thoughts, it's just like him going into surgery with a gun against his head. And you should treat it like that. And sleeping pills is definitely not the answer. But if we had a program in place, a process in place that could get support around him, that could get coping mechanisms to get a community of people around him to help them, checking in, I think he would have a much better chance of surviving. It also brings to question what part culture and religion play with awareness. So although I'm born in London, my mum's from the Philippines and my dad's from Italy. And just like a lot of people in London, it's a real, and Copenhagen is a real mix of ethnic minorities. What was interesting is when my mum found out that her son had died, she's a very religious person, her first instinct was to try and put it under the carpet. She didn't want to tell anyone. In her mind, he's not going to go to heaven, he can't get buried in a cemetery. And there's all these things going through her head of how it just wouldn't be accepted in her family. What was really interesting is that me and my brother felt really strongly that if this could happen to him, it could happen to anyone. So we needed to do something about it. And what she found in the preceding years is that the more we talked about it, the more other people opened up. And it's that moment of vulnerability when you're saying, you know what, this has happened to him. It makes other people more comfortable about talking to us. And that really did help in terms of opening up conversations. The third bit is platforms. Right at the beginning of this talk, we talked about, in the UK, we're doing a lot of work in terms of raising the profile. We're very lucky we've got royals talking about it, we've got celebrities talking about it. So there's a lot of stuff going on around mental health. But it still begs the question, why are 89 men taking their lives every week? So essentially double the amount of people in this webinar today in this room every single week are taking their own lives. So awareness is one thing, but we need more and more platforms for men to open up. When my brother passed, I was really inspired by a UK charity called the Campaign Against Living Miserably, or CALM for short. They try and approach mental health differently, and there's loads of different mental health charities out there. I'm not discrediting any other one of those. I think there is not one size fits all. There's a lot of different options out there, depending on what you prefer. But I really like their approach. They try to make it normal. So they try to break down the taboos, they try and use existing channels. They use sport, football, music to try and bring men in, and then they give them the tools at those places to try and talk about it. Since 2012, I created something called the Mental Health World Cup, which essentially tries once a year to bring men together, play in a football pitch, and have a World Cup in a day. Football is great, but what we're trying to do is trying to get men comfortable with talking about what's going on, give them tools and mechanisms so that if they know someone is suffering, what they can do, and point them in the right direction. I also work, so full-time I work for a construction company called Overbury, who do offices. And what's interesting within construction, and I'm sure is similar across all construction sites around Europe, is it is just like football, it's a very macho-dominated environment. It's very old school, it's very lads being lads and having jokes and lots of testosterone and definitely no signs of weakness in those areas. I think if we're looking for platforms for change, working with existing channels rather than creating new ones is a real beneficial way of doing things. Fourth is looking at education. So following up on Brendan's point, I'm very lucky within the UK and my company offered me recently mental health first aid training. And I know around the UK a lot of that's happening at the moment. There's a real big impetus for that. And I think it's fantastic. It gave me coping tools, mechanisms, lots of stuff that I've been learning about mental health over the last 7 years that I didn't know. But what I find interesting is that why aren't we talking about this a lot earlier? Why are we not talking about it in school? Because when I look back to my education, I don't differentiate trigonometric functions anymore. But it would be really useful to know a little bit about coping mechanisms and coping tools. Mm. When you look at comparisons between, we talk about financials and suicide, I think, yes, there are going to be groups that are going to be a higher priority. We talked about prisoners or homeless people. But I do find that with the passing of my brother, that it can happen to anyone, no matter whether you're a high-profile footballer earning millions of pounds to someone working on the supermarket floor. Everyone has their own issues and their own difficulties. It's how we can approach that and have we got the right tools to support that. Finally, I think leadership plays a big part. I think when you look around the world today, we've got loads of male leaders who are there to be role models, but a lot of them don't show any vulnerability. They're very strong. They still have the archetypal image of the man who doesn't ask questions, who's unfailing in their leadership, who never asks directions if they get lost. And I think it's these figures that I think would really help, having more and more people in the public eye, from politicians to CEOs to celebrities, showing more moments of vulnerability to try and create safe environments. Because I've found when I open up and I be vulnerable, people tend to respond to that. So in summary, I think awareness is improving. It's great to be here today to see a massive report being done on the subject. But for me, this is an epidemic. With over 90 people just in the UK taking their lives every week, I think we're only really scratching the tip of the iceberg. Thank you.
Thank you to all the panelists. And as some of you could see, the questions were pouring in into Slido almost from the time we started. So would someone from the house like to ask a question, or should I move on to the Slido questions first? Okay, I'll probably move on to one of the most popular questions which has come up. And I think it's a very large question, ties in with a lot of themes that are being discussed. But since it's a popular one, let's take it first. So the first question is, what are the greatest challenges to work strategically with an issue as wide as masculinities? And masculinities differ across national and cultural, boundaries. So who would like to take a stab at it? Probably Brendan, would you like to go first?
Yeah, I think it's difficult because men and masculinities are so diverse, both between countries and regions and within countries and regions. So that's why I was saying earlier, which we identified in the report, that any solution or initiative needs to target specific groups. So we need many different programs which enlist the support of relevant members of the community which you're targeting. Otherwise, no one will engage with it. So, for example, a mental health program for young gay men should be very different from one engaging young Muslim men. And then to add more complexity to it, we probably need programs for young gay Muslim men and so on. So, because otherwise you're going to miss some of the most vulnerable and at-risk individuals and groups in our society, which will then contribute more to the mental health crisis and the suicide problems that we have with groups of men.
Isabel, you too.
Yeah, I think that for us, or at least the approach that we are taking with the strategies is, and I think that I also want to say that masculinities is not a negative concept per se. The same as femininities is not a positive one per se. Sometimes it seems like we are talking in those terms, and there are very positive aspects of masculine, feminine societal norms that are beneficial for health also. So what we try to challenge is those that have negative health outcomes, whether they are for men, women, or both. So I think that it is important also to look at the work as masculinities as a means when we are talking about health and mental health. It's not the objective to change it, but to use them as a part of the analysis that we put into the intersectionality, which we not always use easy words, but it is basically what it is, the relation between norms and other determinants of health like income, education, ethnicity, which part of the region we are talking about. And when we work with gender issues, we usually use what is called the twin approach. We target specific populations that are at very high risk with a specific way of doing it. But no matter what we do, we always look at what it is the impact of the determinants of gender norms, of the education, because that's there across countries. So it's about having methodologies that allow us to do this work in a systematic way, because we've also seen that we are not always going on positive trends. And at any time and any moment, if we stop the investment, if we stop the political commitment, can be a drawback. So it's more comprehensive approach to that.
Thank you. Would you like to say something, Giancarlo?
I just agree with both what Brenda and Isabel are saying. I think choice is key. People who engage with services need a lot of choice and need something that they engage with and will want to be part of. I think the main thing is that it needs a lot more drive and direction from local governments. At the moment, there's just not enough being done. The awareness is great, but we need action. And at the moment, speaking from the UK perspective, for anyone who's in the UK or is aware of the epidemic that is knife crime, it doesn't touch the size compared to suicide. But there's a lot of talk in the press about knife crime, about getting new police groups to concentrate on that. So I think we're all aware of the problem, but I think we just need to throw a lot more at it.
Thank you. I'd like to shift gears a bit and move to this question, which is quite interesting, from Dr. Gil Richardson on Slido. And I'm reading out the question, and I'll tie it with another question that has also come up on Slido. He says, with strongmen portrayed everywhere from White House to Hollywood to deodorants, how can a modern man, holistic, in touch with himself, family, and wider world, be validated? So it's a very broad question, but I think it was something that Giancarlo brought up about leadership and what are the models and which are the vulnerable role models that we have and how that sort of validates certain kinds of behavior. So I was just wondering if you could have some comments on that. And tied to that is another question, is why is it that people who are so thinking of themselves as masculine don't seek support what are some of the ways in which we can encourage people to seek support? Maybe we can take both of these, whether these are constricting in some ways, and how can we sort of overcome them? Anybody can go first.
I think when you talk about leadership and showing vulnerability, it's a very difficult balancing act. But I think for me, from a personal point of view, when I look at someone being vulnerable, I find that a lot more stronger than someone just showing that that they're in charge. I think it takes a lot of courage and a lot of strength for someone to open up and to share what's going on in their lives. And whenever a leader has done that, in my personal opinion, I have a lot more respect for them. So I find it a lot more, I encourage more people to do that. I think on the other side, when you're looking at why are men seeking out help? If you look in the history back in the 60s, men don't like going to the doctors. If they've got, my dad would never go to the doctor for a broken leg, or he'd just man up and just get on with it. So when we start getting into mental health, which is much more complex, we already had an underlying issue there where men didn't want to go to the doctors. So how can we find another way? And I think what I found is by using existing channels, trying to normalize it, by using football, by using films, by using the pub, there's different ways to try and approach it.
Thank you. Yes,
So,
Brendan?
whilst it is true that we have political leaders who are subscribing to traditional and arguably outdated notions of masculinity, it's also true that there are a diverse range of role models out there in all walks of life, from sport and employment to other areas, including for younger men. So we must acknowledge the diversity of men in the public eye who are out there, some of whom are actively engaged with mental health initiatives and speaking up. And even the commercial sector is contributing. Some of you might be aware of the Gillette ad that came out recently, which tried to engage with a more positive and expansive notion of masculinity, which received a lot of criticism from men's rights groups and so on, but actually started a really nice conversation about what it means to be a man in contemporary society, particularly a young man. So there are spaces and agents who are intervening in the debate on masculinities and mental health, and creating spaces and language and resources which boys and young men can engage with to the benefit of their mental health and the mental health of their families and friends.
Next, please.
Yeah, I think that on the leadership, I think that you mentioned the fact that the royal family in England, in the UK, has been very forthcoming. That creates a little bit of a spirit. I don't want to comment in the other role models of political leaders that we have, because then we will eat up the rest of the time. But I think that it is important also, and we were discussing it before with the Gillette ad, which was very criticized by men's health groups and very welcomed by women's health groups, on what it is, the transformation that it is being required from one side or the other, right? But I think that as the health sector, one of the areas that we looked at in terms of what you were saying, your father not coming to the service, is making, apart from the other, reaching out men where they are, it's making men familiar with the health services. And there are some good data from the European Union in terms of what is the perception for men and women of your unmet needs. What do you think that the service is not giving you? And men have much less unmet needs than women. And one of the hypotheses and the studies around that is that the less familiar you are with the system, the less knowledgeable you are about what you need. So if men start coming to be familiarized with the health services, how the family doctor system works, how do I come to? And one of the entry points that we find for that is fatherhood. And really transforming the fact that with parental leave policies, men start taking their children to the vaccination, to familiarize with a pediatrician, with a family doctor, that the primary healthcare services we see in some parts of the region, it's said they are being designed for women, but the truth is that it's not for women, it's for mothers. So they are expecting the mothers to come with their children. It's not because the woman has depression or a cardiovascular issue. It's because it's a mother that needs to be healthy, to have healthy kids, and then to keep their children healthy. So if we have that transformations of the services and make men more familiar and the services more men-friendly or gender-friendly, I think that that's also a good entry point, but there is not one solution, obviously. It's many strategies and many sectors involved.
Thank you. May I request my live audience if they have questions? We have Connor with a mic. So, Connor, there is a question behind that goes behind you as well. Yeah, we will take these questions.
Is it?
Thank you.
Hi. Thank you to the panelists for your comments and research, and thank you for sharing your personal story with us. I have a question about standards and sort of guidelines. Often when we present with physical symptoms of something, there are very quick health system-based avenues of which to approach, and I think you touched on this in relation to the doctor experience. But for mental health, do we have guidelines and do we have kind of automatic pathways that get set off as soon as you present with some of these mental health symptoms per se? And then second of all, for WHO, it's a huge concern to reduce out-of-pocket expense. But I feel like for mental health, as soon as you get into solutions, it's actually more about how much money you have and which care you can access. And then once you go even beyond that, I feel like you get into questions about what's standardized, what is a good solution for you? Is what the money that you're using, are you actually getting the care that's standardized or accredited, for example?
Thank you. May I request you to identify yourself?
Oh, my name is Zachary. I work as a consultant in WHO.
Thank you. Maybe we can take the next question as well, and both the questions can be answered together.
We have our expert on mental health.
Hi, thanks very much for the panel discussion, and deepest condolences about your brother as well. Thanks for sharing that story.
Thanks.
My name is Lahiru. I work at UNOPS. So my question is actually based on 3 facts or 3 points. I mean, it is a known fact that more people die of suicide today than from terrorist attacks. And yes, we can even see in the news that more people, like the headlines are always of terrorist attacks or not of suicides, etc. So very much do go with the points which were mentioned earlier. But my question is again on 3 points, which is prediction. So right now, if, for example, let me start with actually prevention. As to all the males who are over here today right now at this point, what would you recommend for us to do in terms of daily activities to ensure that we have stable mental health conditions throughout, and what would you recommend to alleviate such issues? Then prediction. So for example, our friends, family close by, our male colleagues as well, what are the symptoms which you can see when they're talking about their daily lives, etc., that you can see tendencies towards mental health issues? And the last one is on protection of life, which is if, for example, in your case, when your brother said to his girlfriend and to his best friend that I do have these issues, and then the response was go to the doctor, instead of saying that, what else should we be saying, or what else should we be doing?
Yeah, thank you. These are fantastic questions. Maybe our panelists can choose to take all of them or choose to answer Yes, please.
Can I, on the data guidance, we actually have our mental health program manager in the audience, who is the expert of mental health. So I'm sure that in terms of guidelines, what is mainstream, the out-of-pocket, you are in a much better position from a policy point of view, at least, on WHO recommendations to answer. So I would like to Dan Chilson to answer that question, or make an intervention of it.
Yeah.
At least from my part.
Okay.
I delegate on him my part.
Okay, would the panelists respond to any of the very pressing?
I'd like to come in on Yair's very good, very well put questions. I think on the three things that you were looking at, for me, prevention, daily activities to do, I think the more we read about it, the more knowledge you can pick up. I think things like coping tool mechanisms, if you can find out about mental health first aid training, there's a lot of tools out there, but unfortunately, it's hard to find. But Google is a great tool. Looking at that and trying to, as we all try and self-develop our careers, we should be self-developing our mental health well-being. So definitely doing more of those things and would help. I think in terms of the predictions, the symptoms, as you heard from my story, my brother had no symptoms. He didn't have any. He didn't ever say anything about depression. The only thing I would look for are what I would call micro differences, and it's very hard to see now. But I remember the week before he left, I spoke to him, and normally, guys being guys, we don't talk on the phone a lot, but he did speak to me for over an hour. And now looking back, that was one of those things that I call a micro symptom that was different to the norm. So those things are very hard to find. And in terms of what else could that doctor have done, I think at the moment we just haven't got the process in place for doctors to be able to say, okay, that person's suffering with depression, what can we do? I think if there's lots of different ways, there's lots of different things out there, but I think definitely sleeping pills is the old-fashioned way of doing things, and the quicker we eradicate that and start looking at, this is a very complex issue, you need support, you need communities around you, there's lots of organisations that can help, but trying to point someone in the right direction rather than giving them a magic pill, we need to get away from that.
Yes, please.
So in terms of prediction, the evidence suggests that men who suffer with mental health problems but stay silent about it, they do other things. For example, there's a lot of alcohol intake might increase and use of other substances. Risk-taking in general might increase. Overworking, so doing things that are a bit more extreme than normally, even over-exercising. And with some men it might spill out into violence with their partners or with other males. So there is increasing evidence that men who bottle things up basically deal with their depression or other mental health issues indirectly in these other ways. So have these outlets, which of course are ultimately counterproductive and make the problem worse, and lead to a crisis situation down the line.
Yes. Do we have
guidelines
yes.
and the other programs?
We have the Program Manager of Mental Health and Mental Disorders, Dr. Dan Chisholm. We welcome him here.
Thanks
and
very much. Yeah.
He will answer important questions.
I have some thoughts on those, but just to start with, a thanks to all the panel members and the moderator for a really fascinating session. A lot of the discourse on mental health tends to go towards the care and treatment side of the equation, and not enough is devoted to mental health promotion and protection issues. So this is really, really great to see, and particularly with the emphasis on the gender as a social and cultural determinant of mental health, along with many others. I had a couple of reflections, and the first was that when I look at the audience here, and I don't know whether it's the same online, but where are the men? You know, I see about 80% women and 20% men, and this is the same actually as I see in the countries, you know, where we work. You know, often it's that kind of ratio. And I think the problem's facing us right in our faces. It's right in our faces, right? That is a problem of reach. How do you reach and message and communicate with men? And it's different to the way that you communicate with women, right? So I think it was really interesting to hear about some, thinking of innovative non-health sector approaches to engage and interact with men, whether it's in the pub or at the football club or wherever else. There's the famous one of the hairdressers as well, that meant I don't have to go to the hairdresser very often, but men with more hair than me, sometimes talk to hairdressers, and hairdressers have actually become, there's some nice studies of where they've been trained, to listen empathetically. And interact and provide, some form of low-tech intervention. So getting to some of the questions about looking for triggers and prevention. So I think, a lot of it is through empathetic listening. There's something called psychological first aid, just like we have physical first aid. This is something that we'll be raising and discussing over the next month. As was mentioned at the beginning, we have the Suicide Prevention Day starting next week, and because suicide is also the theme for the World Mental Health Day in a month's time, we have a whole month in which we can kind of run a campaign, but both in the region but also more globally. This will contain plenty of materials. There's various printed materials here you can look at as well if you want to find out more. The one I particularly draw your attention to is something called 40 seconds, which is of course the rate at which someone kills themselves through suicide around the world. So every 40 seconds. And this is a sort of general public awareness campaign to which everyone, including everyone here, can contribute through testimonies, messages of hope and support. So look out for that. That'll be starting next on the 10th of September. So I think those are the main things I wanted to mention. Just one other was just about this link to other diseases and injuries, so to substance use disorders, to non-communicable diseases, heart disease and so on, and also to injuries. So there is a close link. We're talking about mental health, but mental health is also in turn a risk factor for some of these other outcomes. So we have to look at it in that sort of more holistic light. Okay, so that's enough from me.
Thank you very much. Maybe we can take one last question from our online audience, and I think this is a question that has been touched upon, but only in an angular sort of a way. So do constructs of masculinity change with age cohorts? And how does this have an impact on mental health? So Brendan can
That's a good question. There's some emerging evidence that with younger groups of boys and men, that masculinity is a bit different compared to older generations. And so the term inclusive masculinity has been used by Eric Anderson and others to suggest that younger men are more in touch with their feelings. If they're straight, they have more gay friends, they have more female friends, they're more tactile with each other. So there is some evidence. It's not really fully established yet, and there is some debate about how strong the evidence is. Certainly, the claims that young men are sharing beds together and kissing each other and touching each other in a friendly way seem to be a bit exaggerated. So we need to do more to look at the evidence and do more research. But I think they're onto something when they say that masculinity is changing. Of course, there are particular challenges for boys and younger men around consumption of pornography and gaming and social media and body image issues. So they can create mental health issues often, for example, around body image. We know that quite a few young men are taking steroids and other substances to make themselves more muscular and more lean. So there are risk factors associated with the kind of situations that young men find themselves in today, but there's certainly something in the suggestion that masculinity gradually is becoming a bit more soft and open and caring, albeit within particular circumscribed communities and with a note of caution.
Okay, so we seem to be coming to the close of our 1-hour lunch webinar. So I would like to remind the online audience that if they've dropped in their emails, we can request our panelists to respond to their questions, those that couldn't be taken up because of time constraints. I would remind our online as well as offline audience to fill out the evaluation forms. The online audience can also do it in the poll section. So finally, on behalf of WHO Euro, I thank our speakers, Brendan, Giancarlo, and Isabel. I must also acknowledge the help received from Lily and Connor, who are here and who work with the office and have helped us in running the event today. Thank you to the live audience present here. Thank you all. And please join us for our upcoming webinars as well. Thank you.